I want to take just a minute to thank everybody who helped put this event together today. Two foundations, the staff from Interact for Health and the staff from the Foundation for a Healthy Kentucky were really integral in making this happen. So if you are from either one of our organizations, would you stand up? And I would really appreciate it if everyone gave them a round of applause. And I want to thank my partner in crime, Rochelle. Can you wave from back there? Rochelle is amazing. She did 80% of the work for this event with grace and poise and many 11 o'clock at night emails. So this event would not be half of what it is without my partner, Rochelle. Thank you. So with that in mind, I want to introduce our next panel. My former colleague and friend Judith Warren is here to moderate the panel. She is the Chief Executive Officer of Healthcare Access Now, and she will introduce our panelists on panel 2. Thank you.
Thank you, Jennifer, and good afternoon, and welcome back to the program today. Sounds like it's been a very rich discussion. This panel will discuss transforming data into policy-relevant information. And I think it's quite timely for the topic, not only policy relevant, but consumer friendly, because data has become more relevant for end users and quality of data is being stressed so much. Data is no longer in the dark, and it's not a scary topic to talk about anymore, making it, again, user friendly. And data help to tell stories. Consumer safety, just translating that information now as we have more sound bites and factoids and trivia statements that go out. Data is very important. Data are very important. And also being concerned about policy and surveillance and privacy. So in that space, there's a lot of discussion going on now, but really, especially in terms of driving the issues of public health. And I think really bringing public health into the forefront and showing the value of public health and data sets in helping with policy. So with that, we're going to hear from 3 different points of view or ways to show about making data policy relevant information, turning that into policy relevant information. So we'll hear today from Glen Mays, who some of you may have heard this morning before lunch. He's the Associate Director with UK Center for Health Services Research, Department of Health Management and Policy in the College of Public Health at UK. Boy, I'd like to see that business card. Secondly, Teresa Reno Weber, Chief of Performance and Technology at the Office of the Mayor in the City of Louisville, has a very interesting project to share in terms of the use of data and how that helped to create different kinds of hotspots. And finally, Chris Clark, from Executive Director and CIO of the Administrative and Technology Services for the Kentucky Cabinet for Health and Family Services. He will talk about transforming access into outcomes with HIT. So we'll hear from each one of the panelists and then take time for questions, comments, discussion at the conclusion of their presentations. So let's welcome Glen.
Thank you. Well, thank you very much. Great to be here with fellow data enthusiasts, and again, special thank you to my good colleague Scott Lockhart, who agreed to swap places with me on the agenda today. I'm going to talk with you about some issues that are, I think, of no surprise to all of you in this room, and that the health system that we all experience here in Kentucky, across the river, in Ohio, and really all across the country, is not much of a system. In fact, more of a disconnected, fragmented collection of actors delivering services. And it's really not all that focused on health. We're a collection of actors primarily focused on delivering care to treat illness. And so pleased to share with you a little bit of the work that we've been doing to use data to help reorient to get more systemness within our health system and to reposition that system a little bit more upstream toward opportunities for health improvement. And to motivate some of this work, I'll share with you some of the data that drives our work. First of all, we know that of the $3 trillion that we spend within our health and healthcare system in the U.S. every year, more than 3/4 of those dollars go to treating the downstream consequences of disease and injuries that are largely preventable. But yet, if we look at the investments that we make in prevention and in public health and in upstream strategies, less than 3 cents on the dollar. And so there's a potential disconnect there that raises the question of are we balancing our portfolio of investments across the health system in ways that can maximize health and well-being for our populations. We also know from some work that we've done that communities that make more investments upstream, that invest more in public health and prevention, they see real tangible health returns from those investments. Some work that we've done shows about for every 10% increase in public health investment at a community level over 15 years yields about an 8% reduction in rates of preventable mortality, which is a good health buy if we compare that to our other health-related strategies, other strategies for improving health. It's also true that there's some real potential economic returns from repositioning our health system more upstream. And again, work that we've done showing that for every $10 invested in public health and prevention at a community level, we get more than 9 of those dollars back over a 15-year period purely in lower medical care cost growth. And so these public health strategies, many of them, some of them absolutely pay for themselves, others of them dramatically cross-subsidize themselves in lowering, over time, lowering downstream need for medical care utilization. We also are learning a lot about what it takes to deliver good prevention in public health at a community level. And again, work that we've done showing that there's no single organization that can make this happen. A broad and robust delivery system for prevention in public health. Work that we've done showing that 62% of the prevention and public health activities that are delivered on the ground in the average U.S. community are contributed by partners outside the formal governmental public health sector. So this is not a role that we can silo to government, nor is it a role that we can only rely on the market and the private sector to do. There's a need for collective action here. And that's where the crux of a lot of our work in using data to try to motivate policy action around creating a system and orienting that system toward health and well-being comes into play. We know that to create a system and to get that system oriented toward health and well-being, we've got a collective action problem. We need multi-organizational efforts that are going to try to achieve a large-scale health improvement, not a one-by-one, but at the level of a neighborhood, a city, a county, a region. We know we've got to target these interventions at fundamental and usually multiple determinants of health, extending far outside of the healthcare and public health sectors into social, environmental, and economic determinants of health. And we got to mobilize and align the collective actions of lots of different stakeholders in government and the private sector. And we need the infrastructure and the support, including especially the data infrastructure, to make this happen. That we know there's lots of reasons why these kind of collective action efforts fail. Lots of good research tell us that. Lack of compatibility and incentives, disconnect between who pays and who benefits, time lags between needing to invest now to see benefits far into the future, uncertainties about the effect sizes we can expect. Asymmetries in information and knowledge across different sectors and actors in the system, difficulties in measuring progress and seeing whether we're making progress, holding these coalitions together. These are the problems that we have to address. What we've done to try to solve some of these problems with data, we've built a national longitudinal surveillance system to track at a community level what kind of public health and prevention services get delivered in those communities and the range of organizations, public and private, that play roles in delivering those services. So we can begin to map out, as you see here using network analytics, map out the types of organizations and their frequency and intensity of working together in supporting evidence-based public health and prevention activities. And we have now a cohort of more than 600 communities that we've been following since 1998 across the country, measuring these activities through targeted surveys, feeding this information back to those communities to say, here's what your delivery system for prevention and public health looks like. Here are the opportunities. Here are the organizations that are central and peripheral within your network. And here are the opportunities for strengthening this infrastructure and this collective action enterprise for supporting public health and prevention. And it's proven to be very popular and helping to inform strategies for, again, creating systemness at a community level and orienting that systemness not just to downstream illness care, but also to upstream health improvement and prevention. We can use this data to show variation across the country, very powerful modalizer. So where are you in the bell curve with regard to implementing evidence-based public health and prevention services? And we see wide variation around the country. We see some communities delivering 100% of the evidence-based public health and prevention strategies that we track in this survey. Other communities down less than 10%. So lots of room for improvement, and also an important equity story that we can tell with these data. We can also reduce that variation and make sense of it. And we use our data in part to develop a taxonomy of what prevention delivery systems look like. We find that basically it's not you've seen one community when it comes to prevention, but we actually identify 7 discernible archetypes of delivery systems in terms of what types of services are delivered, the range of organizations that contribute to them, and the roles and responsibilities within those systems. And it's the first 3 of these typologies of prevention delivery systems, which we call comprehensive systems, are the most robust. They deliver the biggest bang for the buck. They deliver the largest scope of prevention activities, and they do so, they actually do more with less. They require fewer resources to deliver a larger scope of prevention and public health programming and policies. And so being able to show slides like this to show those comprehensive systems do more with less. They deliver a larger scope of activity with fewer resources. We use that in part to help mobilize communities to think about how can we move you upstream from being a limited delivery system to a conventional delivery system up into that comprehensive system where you've got a large scope of activity, a broad range of organizations contributing, and as a result, generating greater outcomes. We can show that first of all, there are tangible health and economic benefits that are attributable to these comprehensive delivery systems, that these systems over time, they produce larger health benefits in terms of reduced rates of preventable mortality. They also deliver larger effects in terms of reining in the growth, the medical care cost growth. And we can also show, as this slide shows, there's an equity dimension as well. Strong prevention delivery systems actually have a larger health and economic benefits in low-resource communities. The bottom 20% of communities across the country we see larger effects attributable to these delivery system activities than we do in the higher income communities. So there's an equity lens and there's some equity solutions that our data can speak to. So what are the policy implications? What kinds of policy implications are we able to support with our data by having this national surveillance system that allows us to capture the structure of prevention and public health delivery systems, who contributes to these services, and ultimately the health and economic consequences of what these systems do? Well, first of all, this helps us make the case that public health and prevention is a good buy. We can show that with our data. We can show health and economic effects. And we can make that case at all levels within our policymaking system. We can make that on the Hill in Washington. We can make that in our state houses, and we can make that at a local level as well. It also helps us get beyond the gridlock by saying, look, our delivery systems for prevention and public health, these are not governmental enterprises. This is government and the markets working in synergy. It is a collective action issue, and so regardless of the political spectrum where you see, regardless of your attitude about government failures versus market failures, we're all in this together. These data help us identify shared interest and shared goals. Where are we working together? Who's at the table, who's not at the table that perhaps need to be when it comes to prevention? Are your hospitals there? Are your physician organizations and health insurers playing a role? Do you have schools involved? Do you have employers involved in others? By feeding this data back to our communities and using benchmarking and peer comparisons, we're able to also help to generate peer pressure, both in the public and the private sectors, to improve it. We can show that some communities can be up there at 100%, and it's possible for all of us to make progress, and we need to put pressure on those who are not central to the system to step up and play their part. This helps us also recognize and reward collaboration. These kinds of data, the network analytic graphs and other activities help help communities and policymakers visualize the level of collaboration and how that collaboration actually translates into tangible health and economic benefits for communities. We can use it for targeting areas of improvement. And again, as I mentioned earlier, they help us tell a pretty powerful story about equity and disparities, not just on the healthcare delivery side, but on the prevention and health production side of the equation. So ultimately, we hope this data helps us align interest, helps us all begin to row in the same direction to ultimately transform our health, not so much system, into a true health system that's focused on health. Thank you so much.